Good morning, everyone. Today, our lecture topic is Pharmacodynamics, Session 2. We have already seen the basic concept in pharmacodynamics like affinity, potency, efficacy, intrinsic activity, agonist, antagonist, and a few introduction to the categories of that. Today, we're going to look in detail of drug agonism, drug antagonism, and a few bit on tolerance. And I'm going to give a comprehensive answer for a commonly asked question. I am Dr. M.I. Shuja, lecturer in Department of Pharmacology. Pharmacodynamics 2. So we'll have a look into agonist. Usually, the agonist activate receptors for endogenous mediators. In the body, I told you, you have receptors created by your body or God. In those receptors, the naturally formed ligand in your body will go and act. Whenever we give a drug, that also goes and bind on that particular receptor. We are producing only the drug. We don't produce receptor. Okay? So salbutamol is a beta agonist. We produce that. But the beta 2 adrenoceptors are already created and situated in the body. So these will go and bind with that, and salbutamol is the agonist for beta 2 adrenoceptor. So the agonist effect may be excitatory or inhibitory. Agonist at nicotinic acetylcholine receptors where in the neuromuscular junction exert an inhibitory effect like suxamethonium. Suxamethonium is a rapid acting muscle relaxant. People used to call that Sux. Okay. Some agonists will inactivate the voltage dependent sodium channel which initiate action potential. So when they are going to inactivate that, the action potential cannot be initiated. When you consider the pain pathways, there is a thing called morphine. We have created morphine and that will go and act on mu receptors, mu opioid receptors. There are 4 and latestly there are 5 kind of opioid receptors, mu, kappa, delta, and mu. These morphine will go and act on the mu receptor. Morphine is the drug we have found, but in our body already there are endogenous mu receptor ligands like endorphin, enkephalin, dynorphins are there. But after we have found the morphine, later only we were able to find the natural ligands, which are responsible for the pain facilitating or pain reduction mechanism in our body. That means in our body, the nature has created ligand and natural receptors for that. We were unable to find or discover all those things. We don't know how many receptors, how many natural ligands we have missed. Okay, that is one example, because after we found the morphine for the pain reduction only, we have got to know there are still naturally produced ligands which act as the mechanism like morphine action. So there are types of agonism. Summation is the two drugs eliciting the same response via different mechanisms. But the combined effect is equal to the summation of both drugs' effects. Like aspirin is analgesic, codeine is analgesic. Both analgesic action is the combination of the each own action. That's why we told 1:1 equal 2. Synergism is a supra-additive one. 1:1 equal 3. So when I say 1:1 equal 3, don't think different thing. Okay, just concentrate on pharmacology. So levodopa and carbidopa, I have taught you in Parkinson. It has a synergistic effect, because if you are giving levodopa alone and carbidopa alone, the effect is 1 for each. But if you combine both and give, overall pharmacological effect is around 3 or more than 2. That we call synergism. The combined effect of two drugs is higher than the either individual effect. Antagonism. The effect of two drugs is less than the sum of the effects of individual drugs. That means if you are going to give, imagine you are giving two drugs. One is an agonist, one is an antagonist. So each by its own have an efficacy. But the combination of that, when it's combined and going to work, that action is less than the sum of the both individual drugs. Okay. There are several types of antagonism, like chemical antagonism. It's mainly for the chelating agents, like heparin and protamine bound, and a physiological or functional antagonism. This is kind of two mechanisms acting to get one response. So one is going to increase, other separate mechanism is going to reduce. So there is a balance between that. That we call physiological antagonism. And pharmacokinetic antagonism, and very important, pharmacological antagonism. And we divide it into competitive and non-competitive. There are other few rare categories also, but mainly you focus on competitive and non-competitive. Physiological or functional antagonism. The substances involved in physiological antagonism act at different receptors or pathways within the body. They don't directly interact with each other, but produce their effects through different mechanisms. Those effects will counteract or oppose each other. For example, one substance might stimulate a receptor or pathway that leads to increased heart rate. Other substance will make or will help in reduce the heart rate. So there is a imbalance. Like norepinephrine increases the heart rate, acetylcholine reduces the heart rate. Okay, both are different mechanisms. Acetylcholine via muscarinic receptors, norepinephrine via adrenoceptor. So if you take histamine and epinephrine, histamine causes bronchoconstriction, epinephrine causes bronchodilation. Different receptors, histamine receptors and beta adrenergic receptors, different pathways, but opposing effect. Then again, if you take insulin and glucagon, insulin promotes uptake of glucose into cell, glucagon increase blood glucose level. So both hormones act in opposite ways. This is what we call physiological antagonism. Insulin tend to reduce the blood sugar level, glucagon tend to increase it. Like I am trying to teach you to gain more knowledge by yourself, but you are refusing to learn. This is physiological antagonism. Okay? Pharmacokinetic antagonism. You know, pharmacokinetics basically four steps: absorption, distribution, metabolism, and excretion or elimination. So any of these steps, if both drugs are competing and because of one drug, another drug's effect is reduced, that is pharmacokinetic antagonism. Like this interference can occur at any stage of the drug metabolism. So absorption, if one drug may alter another drug's absorption and reduce those drug absorption, then it can reduce the bioavailability of that particular drug. Distribution also can affect it. But main interference is come with the metabolism. For example, one drug may induce or inhibit the enzyme responsible for metabolizing another drug. Because of that, they can alter their potential. This is the place where you have to remember enzyme inducers, enzyme inhibitors. Enzyme inducers, when you take with other drugs, like common enzyme inducer is what? Rifampicin. It will go and stimulate the enzyme which are responsible for the metabolism of other drugs. So when you take rifampicin, other drugs metabolism is increases. So their bioavailability is reduces. Opposite happen to enzyme inhibitor. So you have to remember that. Then excretion. During the excretion also there may be competition like penicillin and promethazine. I have explained to you. Okay. So these are pharmacokinetic antagonism like enzyme induction, rifampicin, and phenobarbital increase the metabolism of warfarin, like that. In all these antagonisms, you are supposed to know one or two examples. Then comes the very important antagonism, pharmacological antagonism. Pharmacodynamic antagonism is between two drugs acting at the same receptor, not at the same site in the receptor. Okay? One kind of antagonism acting at the same site of the receptor, site in the receptor, other one is in different site. Okay? There are two mechanisms according to which these one is competitive antagonist, the other one is non-competitive antagonist. Now listen very carefully. Okay? This is very important to understand next two slides. Competitive antagonism is you have a imagine this as a receptor. This is the ligand binding site. So this is your ligand. This tissue is ligand. So this comes and bind with the receptor. Okay. Now it is set. And then the biological messages passes and response happens. This is normal drug receptor interaction or an agonist. It's going to give you a response. So this is normal thing. Imagine the ligand is somewhere there. Now I am going to give an antagonist, a drug, which comes and block the receptor. So this cannot come and sit on the ligand site or site for the ligand in the receptor. But it will compete. If you give two or three ligands or more ligands, it will come when the concentration is increased, it will knock the antagonist out and it will come and bind. Gives you the same effect but at a higher cost. Earlier, to get a response, you need only one ligand, but for this response, you need two or more ligands. That is the basic concept. Okay. The competitive antagonist combine with the same receptor as an endogenous agonist. But it fails to activate it. There won't be no response. When combined with the receptor, they prevent access to endogenous mediator. Usually, the complex between competitive antagonist and receptor is reversible. If you increase the dose of the agonist sufficiently, the competitive antagonist will be knocked off and the receptor will be occupied with the natural ligand or agonist. So this is the equation for that. Always you need more concentration than the agonist alone. So when you are increasing the concentration of drug, but the efficacy is same, what will happen in the dose response curve? Efficacy is same, but to get that, we need to increase the concentration of a drug. So the dose response curve shifted to the right. So the potency of the combined antagonist plus agonist is reduced than the agonist alone. Like this. Agonist alone, when you combine the agonist with competitive antagonist, earlier the competitive antagonist occupy the receptor site. Later, with the increasing of your agonist concentration, the antagonist is knocked off and you will get the same effect like agonist alone. But the concentration at which you will achieve 50% effective response is higher. So the potency is lower and the curve shifted to the right. Whenever in dose response curve, the curves are shifting to the right with the same efficacy, potency is reducing. You all know that. Okay. So what is the most important feature is they say the efficacy is same at the maximum concentration and the effective concentration for the 50% of response is increased. So potency is reduced. That's it. This inhibition commonly observed with antagonists that bind reversibly to the same receptor site as that of your agonist. Okay. So in competitive antagonism, both agonist and antagonist bind to the same site in the receptor. Remember that. Understand that very clearly. So this type of inhibition can be overcome by increasing the concentration of agonist. Like atropine is a competitive antagonist of acetylcholine. Now we come for the another non-competitive antagonism. Okay. So now again listen. It occurs when the antagonist dissociate very slowly or not at all from the receptor, resulting in no change when the agonist is applied. So this is your receptor. My hand is a receptor. This is your receptor site for the agonist. But what happened is this time the antagonist will come and bound somewhere here, not at the receptor site. Via binding here, it will make few conformational changes at the site for the ligand. So it altered. Sometimes ligand cannot comes and fit, cannot bind. Sometimes it may bind, but the binding, the strength of the bind, what we call that affinity, is altered. Or sometimes what will happen? It may bind, but cannot elicit the response. So those are the alteration can happen. Okay. In this situation, even though you increase the number of The agonist, you may not elicit the maximum effect, but at one time in your receptor, antagonist and agonist can be bound. That's the difference. Because those are two different sites. Agonist bind in the agonist site, the antagonist is not bind in the site where agonist bind. That is non-competitive. Okay? Non-competitive antagonism is a situation where agonist and antagonist can be bound to the receptor simultaneously. Of course, they can. Antagonist binding reduces or prevents, either reduce or prevents the action of the agonist with or without any effect on the binding site of the agonist. Understand the concept very clearly. Okay? Then there's another thing called insurmountable antagonism. It is a descriptive term indicating that the maximal effect of the agonist is reduced. And there is a different nomenclature for irreversible antagonist. It is some sort of high affinity binding between antagonist and the receptor, which does not permit the binding of any further agonist on molecule. Okay, so you know you have to know mainly competitive and non-competitive antagonism. There is thing called irreversible antagonism also. But some people think the non-competitive antagonism is irreversible antagonism. Both are not exactly same, but they are overlaps. Okay. So now you have to take a piece of paper and work on competitive antagonism and non-competitive antagonism. Competitive one, the binding of the antagonist to the same site as the agonist, but does not activate it. So it blocks the normal action of the agonist. Non-competitive is the binding of the antagonist while still opposing the action of agonist. So both are there, the same receptor, without competing with it for the binding site. This binds to active site of the enzyme, it's bind to allosteric site of the enzyme. Allosteric site means the different site. It compete with agonist, it not compete with agonist. Chemically resembles the agonist, does not chemically resembles the agonist. As it chemically resembles the agonist only, it goes and bind to that active site. Okay? And here the effect of agonist can be attained by increasing the dose of agonist. You can get the maximum efficacy, but at higher concentration. Here, the effect of agonist cannot be attained by increase the dose of the agonist. You will never get the maximum effect even though you increase the concentration of the agonist. Okay. So this is the usual agonist curve. Here the maximum efficacy is reduced in the non-competitive insurmountable antagonist in the presence of agonist. So this curve is come here. Efficacy is reduced. This again for explanation. This is competitive antagonist. So agonist alone you will get this graph. With the combination of agonist and competitive antagonist, the graph has shifted to the right, but the same efficacy, not same potency. Potency is reduced. This is non-competitive antagonist. Agonist alone, you will get the sigmoid shape graph. When we have agonist is with the non-competitive antagonist, the efficacy is reduced. Here, they use the irreversible antagonist. Both are kindly the same, but not 100%. Okay. Again, I'll give you with the explanation of the drug. Whenever there is an antagonist and there is an agonist, the agonist alone is like that, but you increase the antagonist. So you increase the agonist with the presence of the antagonist. The curve is shifted to the right. Here with the agonist, but you are having a non-competitive antagonist drug. So increase the non-competitive antagonist concentration, your curve is shifted downward. Whenever you increase here in competitive inhibition, whenever you increase the concentration of the competitive antagonist, to get the maximum effect, you have to increase the concentration of agonist also. The more competitive antagonist, the more increased concentration of the agonist. So the curve is shifted to the right. Here in the non-competitive inhibition, whenever you increase the non-competitive antagonist, the efficacy is further lowering down. The efficacy is coming down. Same thing I have explained here. So there are two excellent pharmacological scientists, Gadum and Shield. They have found an equation to check the potency of the antagonist drug. So antagonist drug, the B is the competitive antagonist drug. So the KB is the, what we call KB is the dissociation equilibrium constant for the reversible reaction of the antagonist. That means competitive antagonist. So whenever the lower the KB, the more potent the drug. So you just go through. We don't expect you to know how the equation comes, but we have to know whenever the dissociation of the antagonist is lower, it is more potent. It binds to the receptor very potently. Okay. These are the few graphs just go through. And these are definition. Just go through and you will understand. What is competitive antagonist? All these equations are used for competitive antagonist. What is non-competitive? What is irreversible? What is insurmountable? If you don't understand these two, it is fine, but understand competitive and non-competitive. In some books, for the competitive antagonism, they say reversible antagonism. For non-competitive antagonism, they say irreversible antagonism. But I still use the words separately. Competitive antagonism, non-competitive antagonism, irreversible antagonism. Insurmountable antagonism means the maximum effect of the agonist is reduced. It is not affected by increasing the agonist concentration. Irreversible antagonism is it is insurmountable but does not have to be non-competitive. Okay. An example is an antagonist which binds covalently to the receptor binding site. So when it binds very tightly also, that becomes irreversible. If you understood the difference, that is fine. If not, don't worry. Don't worry. Understand the competitive antagonism and non-competitive and the difference and how it appear in the graph. That is fine. Then we'll come to the agonist. Especially, we'll see partial. Some drugs combine with the receptors and activate them, but are incapable of eliciting maximal response, no matter how you increase the concentration. That means there are few drugs, say a kind of same like the agonist, but it goes and bind with the receptor, but they cannot give you the maximum response, even though you increase the concentration of the drug. Okay, those are known as partial agonists, and they have a kind of therapeutic importance as well. So these are the full agonists. It has maximum efficacy. Partial agonists, they don't have the maximal efficacy. If a partial agonist is used at the same time as a full agonist, so imagine the partial agonist and full agonist, they are going to use at the same time. They both have same affinity for that particular receptor site. So both will come and occupy that. At that time, the partial agonist will be act as an antagonist, a kind of competitive antagonist. Okay. So these partial agonists will competing with the full agonist for the finite number of binding sites. Some partial agonists bind with the receptor, and that receptor drug complex may not be activated. So that will reduce the total drug effect. Okay. But if you give a sufficient amount of high concentration of full agonist, that can be displaced and you will get the same potential or full, not the same, not potential, same potential effect. That means we'll get the same efficacy, but the potential is reduced because you are increasing the concentration of the full agonist to get the maximum response. So this is your full agonist, this is your partial agonist. When full agonist is the presence of the partial agonist, we will still achieve the maximum response, the efficacy, but at a higher concentration. Okay. The full agonist can elicit a maximum response when only small proportion of the receptor is occupied. That's a theory called spare receptor. That means there are few receptors. The drug no need to go and bind to all the receptors to get the maximum response. If it bind for the few receptors, that is enough to get the maximum response. Because I told you earlier, there's a graded response of the drug. That's why you will get a graded sigmoid shaped curve, increasing gradually initially in the drug response curve or dose response curve. Okay. However, this is not the case with partial agonists, where substantial portion of receptors need to be occupied to cause a response. Full agonists can act on pair receptors. That's the concept, right? But the partial agonists cannot. They have to act on certain amount of receptors. They have to occupy certain amount of receptors to elicit their response. That means reduce response, then the maximal efficacy. But for the full agonist, it can bind to a small portion of receptors, that is fine. There are two clinical consequences. We have seen it earlier. The partial agonist antagonize the effect of full agonist. Because most of the receptors are occupied with low efficacy partial agonists, the full agonists have to compete with each other. It is more difficult to reverse the effect of partial agonists, so you have to increase the concentration of full agonist higher. This is again a drug A, full agonist. D is partial agonist, the efficacy is reduced. The B is ones with a competitive antagonism. The efficacy you will get the same as the full agonist, but it will come at a high concentration. Your graph is shifted to right, so the potency is reduced. In non-competitive antagonism, the graph is shifted, you will never get the maximum efficacy. Okay, so these are full agonist, partial agonist, agonist with competitive antagonist, agonist with non-competitive antagonist. All four entities are in one graph. Okay. Now you can get together and discuss with your friend what are the potency of each drug, what is the efficacy of each drug, how you are going to shift the curve to the left, how you can shift the curve to the further low. For this graph C, if we want to shift this curve to the further low, so further reduce efficacy, what you have to do? You have to increase the concentration of non-competitive antagonist. Like that, you can work. That's how you learn the things. Studying and learning are two different things. I expect you to learn the things. Okay. Then another concept, receptors with constitutive activity. That means for few receptors, especially G protein coupled receptors, you don't need the ligand from outside, or you don't need a natural ligand to stimulate that. They are a kind of automatically or spontaneously stimulate and express, and they give the response. But in physiological condition, this kind of spontaneous activity is very much low. In pathological condition like cell growth and transformed tumor cells in the cancer, this activity is high. Okay. So there is thing called inverse agonist. They many conventionally classified competitive receptor antagonists. They have a property of inverse agonism. What it actually do is, there is always a basal activity for a receptor. It goes and bind, and it in the opposite side it activates the receptor. The inverse agonist is an agent that binds to the receptor as an agonist, but induces the pharmacological response in the opposite direction. Okay. In the absence of basal activity, such inverse agonist would behave as a competitive antagonist. When you have the basal activity, it's going to do an action on the opposite way. This is the full agonist. This is inverse agonist. In the inverse agonist, the action is on opposite way. There are few examples for inverse agonists, like beta blockers, antihistamine, and few other things. So this is again a graph. You just need to know this is a full agonist, partial agonist, neutral antagonist, no effect at all, and inverse agonist. And again, I gave you a definition from the standard pharmacological book. What is full agonist? A full agonist reaches the maximum response of the system. A partial agonist does not reach the maximum response even at the full receptor occupancy. An inverse agonist is a ligand that binding to receptor reduces the fraction of them in an active conformation. Okay, it reduces the fraction of the binding receptors and exert the effect in the opposite way. And few other definitions: allosteric modulator and spare receptors. I told you, said to exist wherever a full agonist can cause a maximum response when occupying only a fraction of total receptor population. When there is a spare receptor population, a full agonist to exert its maximal effect, it does not need to bind to the whole receptor. A binding of few receptors is fine to give the maximal effect. But for the partial agonist, it has to bind most of the receptors in a given receptor population. Know the difference. And there's a thing called slow process, that is down regulation. When a receptor is exposed prolongedly for a certain agonist, it can cause the down regulation of the receptors. That is desensitization. So what will happen is, when you are exposing a receptor for the long duration of agonist, the membrane receptor may become internalized. So receptor downregulation happens. And G protein mediated linkage between the receptor and effector enzymes may be disrupted. So when there is the receptor and effector enzyme relationship is disrupted, even though it binds, you cannot elicit the response. Okay? Desensitization is probably involved in tolerance that occurs during prolonged administration of drugs, such as morphine and benzodiazepine. When you give morphine continuously, people will get a kind of tolerance, like they need more concentration of morphine to exert the same effect which is previously achieved with the lower concentration of morphine. That is tolerance. And there are a thing called tachyphylaxis and tolerance. That's the homework for you all. You have to find the difference between tachyphylaxis and tolerance. Tachyphylaxis is rapid. Tolerance is long term. So therapeutic effect sometimes depends on the induction of tolerance. For example, in your body, gonadotropin releasing hormone is secreted in a pulsatile manner. It's a pulsatile secretion, not a continuous secretion. So it is one of the factor for the prostate cancer. When there's an increased secretion of pulsatile secretion of gonadotropin releasing hormone, you will get the prostatic cancer. So what we do is we give gonadotropin analogs like goserelin externally will give continuous treatment. So initially, for these drugs, the gonadotropin release is increased. So LH and FSH are stimulated in high amount. But with the time, with the continuous exposure of the drug, the goserelin, to the receptor, will cause receptor desensitization. So the effect is reduced. The LH and FSH are suppressed. That is one of the therapeutic effect of induction of tolerance. It can be asked in your SEQ. Explain the pharmacological basis behind using goserelin in metastatic prostatic cancer. You should be able to explain. So you have to, writing this not enough, you have to give a good account of what is tolerance, what are the mechanism of tolerance, how the action of goserelin affects those mechanisms and how it works. Okay. Conversely, reduced exposure of a cell or tissue to an agonist can increase the receptor number, supersensitivity. Like the prolonged exposure of beta blockers, what happened is your beta receptors cannot initiate any action. So your body will produce more and more receptors. Then you suddenly stop beta receptors, what will happen? The beta agonist activity is suddenly increasing. That's why you are getting tachycardia and worsening of chest pain and everything. That's why in patients who are on beta blocker, especially the blocking drugs, we are tail off it gradually to avoid this supersensitivity scenario. Because your body is having norepinephrine, adrenaline, everything, they naturally produce beta adrenoceptor ligand. The beta blocker is blocking the action. So they fight, still not working. So body think, okay, I need more receptors and it produce more receptors. But that receptor is also blocked by beta antagonism. When you suddenly withdraw this beta blocking effect, you have more receptors, you have more ligand. So they come and bind. Okay. Like boyfriend and girlfriend meet after 5 years. They went for their studies in foreign. They come after 5 years. They meet. What happened? Explosion, right? That is what happens here. To avoid that, you have to gradually withdraw the beta blocker. That is supersensitivity. So then there's a non-receptor mechanism I have told you in the last lecture. So just go through that. And is a homework. You have to go and read about tolerance and tachyphylaxis. Have a note. And as I told you, and I know you are a brilliant student, you might not have question now, but if you have any questions, you can contact me via WhatsApp or email. And this is one question. I have given you a comprehensive answer. Okay. A non-competitive antagonist, when bind to allosteric site, how it alters the receptor site for agonist. So usually, a non-competitive antagonist bind to the receptor site distinct from the site where the agonist typically binds. This alternative site is we call allosteric site. Allosteric sites are regulatory site on the receptor. When they bound by ligand, they induce the conformational change in the receptor. So what are the conformational changes? These conformational changes reduce the affinity. It may reduce the receptor affinity for the agonist at the binding site, so making it harder for the agonist to bind effectively. Then they affect the activation. Even though they, with the hard or with difficulty, the agonist bind to the receptor, it face further difficulty in fully activating the drug receptor complex and modify the signaling pathway. As a result of these conformational changes, the receptor's response to subsequent binding by the agonist is altered. The antagonist does not compete directly with the agonist for the binding at the orthosteric site. Orthosteric site is the primary site where the natural ligand or agonist will go and bind and exert the effect. The reduction in response is due to the altered receptor conformation, preventing the full activation or signaling efficacy upon agonist binding. The non-competitive antagonists often bind irreversibly or with very slow reversibility to the allosteric site. These non-competitive antagonists, if they are moved from the allosteric site, the conformational changes exert on the proper primary site is come back to normal. So the efficacy will be attained. But these have very slow reversibility or irreversible. This action of irreversibility or slow reversibility further help in the long lasting effect of the antagonist. Okay. And with that, may peace be upon you all. And we come to the end of pharmacokinetics and pharmacodynamics. We have 4 lecture series. I have covered all the basic concepts. So, but still, I recommend you to go for the further reading to sharpen your knowledge. Thank you very much and have a nice day.